Welcome back after the lunch break. We will follow the sessions, post-lunch sessions. The first one is immune modulation in elderly. And for that, we have our chairperson, Dr. Kirit Vyas. I request Dr. Kirit Vyas to please introduce the speaker. Kirit, you muted. We can't hear you.
Yes, sir.
Yes.
I'm audible now?
Yes, you are.
Thank you very much, sir. And one of the now it has become more prestigious, this knowledge forum. And good afternoon to Dr. Sadhana also. She is one of the Dr. Sadhana Sharma. She is one of the eminent speaker, and she is professor and ex-head of the Department of Medicine, NRI Medical College, Guntur. And she is also an ex-associated professor of KMC Manipal. She is a member British Genetic Society and Curriculum Committee of NTR, University of NTR, Andhra Pradesh. She has various national and international lectures in her name. And today her topic is immune modulators in elderly, and which this particular immune system and immune modulation has drawn attention in the coming years. And one of the, I think, best topic to and wise will make more wise for us is over to Dr. Sadhana Sharma.
Hello.
Yes, madam.
Yeah, good evening, everybody. I feel privileged to have been given this opportunity by Dr. Anand Meenawat sir and Dr. Y.S. Raju sir, ex-HOD of NIMS Hyderabad, and in this third National Digital Forum. Now, I'm also thankful to Dr. Anand. Sir, thank you so much that you have given me this post-tea slot, because the topic being so dry, at the same time, the most talked about topic today, I think the tannins and caffeines keep everybody hooked to the screen. So what I am going to discuss is in the next 20 minutes is, we'll just refresh about immunosenescence and what is immunomodulation. And then we contemplate why is it needed in elderly, how do we achieve it, and what is in store for us. So this was a term as coined by Roy Walford. It is an age-related involvement of immune system, which leads to progressive reduction in ability to trigger effective antibody and cellular responses against infections and vaccinations. Now, as like any other disease and illnesses, immunosenescence aging is also multifactorial, determined by genetics, nutrition, exercise, sex, any previous exposure to microorganisms, and human cytomegalovirus seropositive status. Now, when we look for sex, it is very important to know that we see that estrogen has immunostimulant properties, while progesterone and testosterone have immunosuppressive properties. Now, probably this is one of the reasons, or the other reason being that females as such have a longer life expectancy than males, that we see immunosenescence is achieved earlier as compared to females. Herpes infection is again one infection which is known for his latency and chronicity, and it seems to alter the T cell environment. Similarly, by 70 years of age, almost 70% of elderly are seropositive for HCMV status. So what we are looking at is this HCMV status also alters the T cell milieu in the body. Now, the hallmarks of immunosenescence are reduction in the number of peripheral blood naive cells, that is our T cells, B cells, NK cells, dendritic cells, etc. Associated with a relative increase in frequency of memory cells. Memory cells are the ones which are exposed to some antigen in the past, and they can react again with the fresh infection with the same antigen. And then is inflammaging. Again, this is an emerging term which I'll be discussing further. So let's go to what happens to thymic gland. This is the main gland responsible for our adaptive immunity. So when we see, you see by the involution or the atrophy of the gland starts right from the first year of age, and by the age of 70 years, what we see is around 10% of the thymic volume is what is remaining in an elderly person. And we know this is the place where the T cells are selected and mature. So this is what happens. We are losing a chunk of thymus by the age of 70, and which is probably the culprit for a lot of our adaptive immunity loss. Now, while innate immune cells, they display the functional defects, such as they have decreased phagocytosis, decreased cytokine production, decreased chemotaxis, decreased reactive oxygen species production. We see along with that, the adaptive immunity cells also degrade in terms that there's a decreased class switching, there is altered receptor diversity, and there is a decreased antibody production. And in nutshell, what happens, these two together lead to an increase in pro-inflammatory cytokines like interleukin-6, interleukin-8, and TNF-alpha. So this is again a pictorial representation of what are the changes which happen in our immune system and how they contribute to inflammaging. Now, what is inflammaging? So we say inflammaging is one of those persistent, not resolving, low-grade inflammation during aging that fails to move to an anti-inflammatory state or repair tissue injury. Now, this is one of the most important reasons for autoimmunity, which we see in elderly. This is mediated by TNF-alpha and interleukin-6, and this is what is contributing to cardiovascular disease, type 2 diabetes, cancer, and neurodegenerative disorders. Immunomodulation, yeah, this is what we are going to talk about today. This is what is the therapeutic intervention to alter the immune response of the body. It can happen. It is where it is very well protected in young, but still in young with organ transplants or immunodeficient diseases, we need immunomodulations. But in elderly, because of immunosenescence, we got to have immunomodulation. So this is adjustment of immune response to a desired level. So it can either be potentiation, it can be suppression, or it can be induction of immunologic tolerance. Now, how do we achieve this potentiation or augmentative response? Is we, in cases like to prevent infection in immunodeficiency states. Now, when we look at something like acquired immunodeficiencies, as in, malnourished elderly, what we have to do is we have to restore the nourishment. Or acquired infective diseases, commonly HIV, we use antiretroviral therapy. We are still in the quest to discover an HIV vaccine. If the person has already established infection, so we need to fight them, and in that process what we do is we shift immune response of our naive T cells to attain a Th1 phenotype. And yes, for fighting cancer, again, this is cancer has a very as a very positive outlook, probably because of the discovery of immunotherapy. So we have, this is one of the preferred target for immune system, and we can use tumor specific antibodies, cytokines, and cellular therapies. And what are the conditions where we achieve immunosuppression? So when we talk about allergy, we go for specific desensitization. In autoimmune diseases and organ transplantations, we can suppress the immune system, or we can almost abort the immunity is by interfering with the antigen presentation, like anti-CD54 molecules, or by activating T cells that is characterized by cyclosporin, tacrolimus, and by proliferating the T cells, which is characteristic of MMF, leflunomide, and sirolimus. So now, why do we need this immunomodulation in the elderly? So as we see, we as a world are approaching towards a population above 60, which maybe by 2050 would reach a point of 2 billion. And we physicians have to be prepared to handle this population. And what happens in elderly? So this aging immune system, what it causes is, it causes increased susceptibility to infections. It causes increased susceptibility to development of autoimmune diseases, and they are poor responders to vaccinations. Now, all these contribute together to high hospitalizations, leading to increased morbidity, mortality, and an increased burden on the healthcare system. So that is the reason probably we need immunomodulation. Increase in lifespan doesn't imply that there is an increase in health span. And that is the reason why we want to, we want to interfere with our immune system so that we have an entire population of elderly, me and you, who are not dependent on our parents, who are not dependent on kids, who are not dependent on the system, especially the systems in developing countries, and we are able to live a reasonably good, healthy life. So how do we achieve? Now we say that, for aging, it is a malleable process, and it is affected by both nutritional and pharmacological interventions. So if aging is affected by these interventions, that means it is possible that if we intervene in our immune system, maybe we also, we could modulate this system by these interventions. So foremost is diet. Now diet is the most talked about in almost, it is a universal intervention in almost all the diseases, be it cardiovascular diseases, metabolic diseases, cancer, or anything. Same is to prevent senescence. So we all know about, it is a very, very, Mediterranean diet is it is a known guest in every doctor's house at least, and the Googler's house also, which comprises of fruits, vegetables, whole grains, reduced consumption of animal proteins. And how does this help? It downregulates the pro-inflammatory mediators like intracellular adhesion molecules, vascular adhesion molecules, CRP, and interleukin-6. The other intervention which we can probably go by is calorie restriction. This again downregulates the activation of pro-inflammatory cytokines. Cycles of fasting, mimicking diet, long-term fasting. This is what we are talking for quite a number of years now with respect to type 2 diabetes. But then we do have a role of these fasting states in reducing inflammation also. What is this mimicking diet? We all know it is a diet which had been prescribed that you have 5 days, you have pre-packaged meals of low calorie and high fat diet, and and this is what probably by antioxidants and anti-inflammatory effects, it may delay the immunosenescence. So they could be probably disposal of damaged cells with growth of new functional cells. Metformin, yeah. Again, there is a lot of halabala about this metformin, and this halabala is definitely not without reason. It is probably again proposed as an anti-aging molecule for humans. It acts through the 5-AMP activated protein kinase pathway, and let's hope that it gives us also a portion to have a healthy life. So this is also known as calorie restriction mimetic. Now, how is our approach in diet going to be for malnourished elderly? What we spoke about is about the people, who had been well nourished and who had been aging with a reasonably good pace. But we do have this poor class. We do have this this class who is malnourished in both being overnourished or undernourished. So we can use supplements in these like zinc, copper, iron, vitamins, nutraceuticals, and probiotics instead of calorie restriction. Now, this was a prospective randomized control study where they found that there was a immunomodulatory effects of glutamine-enriched nutritional support in severe sepsis. How much can we extrapolate it for the elderly who are not having any predispositions is yet to be decided. Again, the next beautiful thing which is there in armamentarium for every disease is without investing anything is probably physical exercise. So we have this increasing habitual physical activity, which is moderate strength. So what is important is moderate strength and endurance training and exercises, which will enhance the innate immune functions. What we saw is this in aging, usually what we have is predominantly it is the acquired immunity which is more affected, which is affected along with the innate immunity. So this is indicative of reduced infection risk and inflammatory potential. It also helps in reducing the risk of cancer. This illustration is a concise representation of all the interventions for reducing inflammation. Toll-like receptors are again most talked about. So if there is an upregulation of these receptors, as with physical inactivity, this also induces a pro-inflammatory stage, thereby leading to senescence. Probiotics, prebiotics, symbiotics, terms which are definitely very, very common to our ears is the lactobacillus and bifidobacterium. Again, they lower the production of TNF-alpha, interleukin-1 beta, and interleukin-6. Nutraceuticals. This is a wide spectrum of bioactive ingredients which help with osteoporosis, arthritis, allergies, GI diseases, cardiovascular diseases, cancers, and whatnot. And they are usually plant-based foods and found in fatty fish. So these are a different class like carotenoids. So they have done study with high doses of beta carotene, which increase T helper cells and NK cells number. They tried with they're trying rather with dietary polyphenols, especially coca polyphenols, olive oil, and resveratrol, which is seen in our favorite red wine and berries. And it reduces the expression of CD40, CD36. Again, omega-3 PUFA, that is omega-3 PUFAs, which are rich in fish products, flax seeds. They have anti-inflammatory properties by inhibiting the formation of eicosanoids and synthesis of pro-inflammatory cytokines. This again tells that exercise, nutrients, antioxidants, and essential amino acids like tryptophan, they help in neuroprotection, they help in the prevention of depression, and they restore the mucosal immunity and homeostasis in GI tract. So we have, as this is a repetition again, water immunostimulants which induce the immunity, increase the immunity, and you see we have a big armamentarium, a very big plethora of agents which are used in immunostimulants, but how much of them are going to be used in our clinical practices is a thought to ponder about. Same with immunosuppressants. Yes, immunosuppressants we are using quite routinely, especially in organ transplants and stem cell transplants, but immunostimulants what we are looking for. Now, with all this, what is there in store for us? So we have these newer things which are ongoing: the checkpoint inhibitors, the mitogen activated protein kinase inhibitors, and the mTOR inhibitors. So we have growth factors like interleukin-7, which enhances thermopoiesis predominantly in lymphopenic older individuals. Immune checkpoint inhibitors, these are monoclonal antibodies that inhibit the expression of certain proteins made by T cells and some cancers, or antibodies that block the activation of inhibitory receptors. The prototype being nivolumab, which is used in metastatic melanomas in young patients. They're trying it for elderly. Ipilimumab, which has anti-leukemic properties, and this is tried again in elderly, where it is used basically in young patients. Then we have mitogen activated protein kinase inhibitors, which target the memory cells. Vaccination. Now, this is something which is the most important and most successful manipulation of immune response. What is important is that overall vaccine efficacy of different vaccines which are available remains low in elderly. That is because of the impaired ability of the immune system to respond to immune stimulation. So we have So we have the newer tools to manipulate the response. We can use cytokines, we can use viral vectors, we can use naked DNA. Importantly, newer adjuvants. So we know that traditionally we have been using aluminium as adjuvant for different vaccines. So what we have tried is they have been trying with MF59 as an adjuvant for influenza vaccine, and by increasing the antigen presentation and activating innate immunity. So what we found is that influenza vaccination as such has only 70 to 90% efficacy in young adults, while it is only around 17 to 53% in elderly. So maybe by these manipulations, we will be able to make the vaccine more efficient. They've also tried the different routes of administration. That is, instead of giving IM route, we can probably try with the intradermal route, but they did one study with this and they didn't find much of the benefits. Trained immunity, it is a new emerging concept. So we all know that for a long time, development of immunological memory was solely attributed to adaptive immunity, which is maintained by antigen-specific, long-lasting memory lymphocytes. And they recognize the pathogens to which they had been exposed in the past. While innate immunity is maintained by non-specific effector molecules, which are devoid of memory proportion. So with innate immune memory, this is an emerging concept which shows that innate immune cells possess non-specific immunological memory established through epigenetic and metabolic reprogramming upon encountering certain pathogenic stimuli. And how does it help? It helps by enhancing the immune responses against infections, and it helps in the improving efficiency of vaccinations. Now, prototype of this, what the trials are going on, is BCG vaccine, which came back again to everybody's lips was during the pandemic COVID. Many people tried with this for preventing COVID infection, but what we have seen is it is being used for the treatment and control of non-muscle invasive bladder cancer. They're trying it for leishmania and Plasmodium falciparum infections also to boost immune responses. Now, when we see, we have gone through a whole lot of T cell, B cell, NK cells, DC cells, and everything. It looks very nice, very confusing, very fancy, very lucrative, very positive. But ultimately, what we see is the mainstay remains diet, physical exercise, nutraceuticals, the time-tested always. But we are hopeful of the bright future, that is the newer immunotherapies. So I wish Dhanvantri again reappears with his kalash containing newer immunomodulators. He gave immortality to devatas, but let us get a very good, healthy lifespan for us if we survive till then. Thank you so much.
Thank you, madam. Thank you very much. In fact, such a precise discussion of immunomodulation, especially in the elderly, we have never come across. You have really summarized such wonderfully that everything has just gone inside without any hassle. But then there
Thank
are
you
certain
so much.
there are certain typical questions. Now, these are things which, other than nutraceuticals and exercise, which of course are being practiced day and night by all the practitioners. What practically is available other than nutraceuticals and physical exercises? Of course, the diet and other things are, of course, in practice. But then, do we really think that, do we have solid evidence, like we have gone through literature for metformin, we have gone through literature of a lot of vaccines, but anything in pipeline which we think will be available in our lifetime? If there is anything you can tell us about.
Yeah, that's what I was saying, sir. Probably what I projected in the last few slides was regarding the things which are in pipeline, and I really don't know. I have completed my half century, so I really wish that maybe these things are available for me to pull through for for the future. But till then, maybe I would also continue with the old time tested, old is gold, that is diet, physical exercise. Yes, these are very fancy, and we hope we get it. So, but whatever I went through the literature, as of now, everything is in pipelines. Nothing is available.
Okay, thank you. Let us hope we get something very quickly. Wonderful hearing you, madam. It was
Thank you so much, sir.
Pleasure hearing you so wonderfully. Thank you very much for the time you have given us. So nice of you. Thank you very much.
Thank you, sir. Same here, sir. Thank you, sir. Thank you.